we are speaking about the special situations when we are doing enucleation. I am going to show you some videos, and what I would like is a very practical session just to share with all our audience. What do you do in these special situations that sometimes they are difficult to face? You don't know how to manage the situation. So please, let's try to be very, very practical and please share your expertise with our audience. So the first thing is I am beginning doing enucleation, and I cannot find the plane. Which one is your strategy? What suggestion you give to your audience to find the plane? Where is the place where you think it is the best place to find the good plane between the adenoma and the capsula? Please, go ahead.
Since I'm a bipolar enucleist, I really like the small holes you have around the veru. And I noticed that you only need to make kind of a lateral movement often, so you don't have to cut a lot of tissue to get there. But of course, that's the mechanical way to find the plane. But I think a lot of beginners are very nervous about finding the plane. But in the end, I think that's not the difficult part.
Fernando, you began doing enucleation with green laser, that is lateral shooting, not frontal shooting. So, where do you look for?
We did. I think if you look for the floor of the veru, on the side of the veru, you can do either a mechanical swipe or you can do energy swipe. The problem with these new lasers is that they spoil the beautiful plane that we can see when we do mechanical enucleation. So if you try to dissect this plane, you no longer see the beautiful surface. So many people are a little bit stressed with that, and I think we have to change the paradigm. We don't want to see a beautiful plane anymore. We need to see a capsular plane, and to me a capsular plane is a plane that it's smooth, white, fibrous, and it's not perforated, and that's enough for me. So we have to change. Many people try to look for the beautiful plane, but many times it's not there, and many times you have to settle for a capsular plane. Sometimes you're 1 millimeter below the real plane, sometimes in the real plane, but it doesn't make a big difference. If you deepen the capsule, then of course you have to correct, and this is the way I simplify the issue.
Javier, Giorgio, your strategy?
I agree with Fernando. I think that the main thing is to find the right plane. The right plane is easier to find when there is a small tissue. Small tissue is at belumospontanum and close to the bladder neck. I think it's easier for the beginners to start here, just on this point. And I practice a different enucleation. I never do mechanical traction, so I only use the laser. I agree with you. New lasers can let you find perfectly the right plane without any traction. Obviously, it's not so beautiful as, for example, the green lab. The enucleation with green lab is beautiful. It's anatomical perfect, but it's not necessary. And I think, in my opinion, is less dangerous for the continent because you are never pushing, and is less injury for the structure of the urethra, less damage of the sphincter. For me, is this. So for the beginners, I think work with laser, new lasers is easier, and the same as has said Fernando, it's not necessary to find exactly the beautiful anatomical plane. Only to find the capsule plane is enough.
Giorgio, do you have a favorite laser? Do you think with one laser it is easier to find the right plane, or you don't mind?
I can tell you I don't mind, so any of the comment is correct and with them, because it's you have to find a plane where there's less place in between the adenoma and the capsule itself, and just at the apex it's that area. and when it start going up the adenoma. So you just make a little push on the side, on the left or on the right, and you just find out that plane. So then you can use the laser to buzz the vessel, and you just follow that line. It's quite simple. Once you understand these, it's easier to keep on. And so this is why finding out this play can easily shift from the 2 or 3 lobe technique to the en bloc, because once you find out the correct plane, you just can follow it. And in the 3 lobe or in 2 lobe, you have to find the plane in different way, and so it can be tricky. Sometimes you have a plane on a side and another plane that millimeters to keep or to lose that Gómez was telling us about before.
I would like to say something to beginners. The easiest place to find the right plane is in the Beru. But if you find the plane in the Beru and you go from the Beru to the bladder, you're in dangerous because you can go subtrigonal. And when you are subtrigonal, you are in dangerous. That is, for me, the only hole I am afraid of. You can make holes in the capsule in several places and nothing happens. But if you go subcapsular, you begin putting liquid to the retroperitoneum, and then you can be in trouble. So the easiest place to find the plane is in the Veru. That is the reason because I began in the Veru. But then I go to the bladder, and then I make that 6 incision, trying to look for the incision I am doing here. It is safer coming from the bladder to the Verum than from the Verum to the bladder. For beginners, for people with experience, it is exactly the same thing. And for me, that I do enucleation with all the lasers, and I feel very comfortable, but I have to say that I have done more than 4,000 enucleations in my life. I think holmium helps in the beginning more to find the right plane, because the peak power is higher, and then it is pushing the adenoma, and then it is easier to find the plane. But in the other hand, the Mostasia is worse, and then each laser has differences, so I cannot say there is a better laser, but to find the plane, I think it is easier with the holmium. I don't know if you agree with me, what I am saying.
I agree. I think that the holmium peak power produces a bigger explosion in the tip of the fiber. So the behavior of the holmium is like a small scissor. Every time you fire a pulse, it's like opening the scissors to dissect the plane, because there's some expansion. But with lower peak powers, the bubble and the mechanical effect, the wave, the pressure wave that these bubbles generate is much lower. So it's more a cutting effect. So it would be like enucleating with a knife rather than the scissors spreading.
Completely agree. So the new TFL is helping in this. The old thulium continuous wave, for me, it's very difficult to find the plane, and I have to do more traction. So that is my experience. I have no level of evidence about this. So if we look here, I always begin doing this just in the area of the Veru. I do my incision in the above the Veru, and then I am trying to look for the right plane with the laser, not pulling, just I will pull a little bit because sometimes you need it, but you can see that the plane is developing very, very easily, and then you have the plane, okay? So look for the plane in the area of the Veru. You can see very well the difference between the capsula and the adenoma, and then you can begin working and you can be developing the plane. One more important thing, it is that it doesn't exist one plane. It exists several planes, like in an onion. You have to choose your plane and to follow it. There is no only one right plane. I think it does exist several planes, so this is a very demonstrative case how I do it. This is a TFL laser, so you can see like with a TFL also you can find really, really well the plane. So we can also have other opportunities let me see, like like here. Here, what I am doing is that sometimes you cannot find very well the plane, and then you can pull a little bit, like you do with the finger. I don't like tractions. I try to avoid them as much as I can, but sometimes you are a little bit lost, you cannot find it, or you have some adenomas in the area of the veru, and then you don't know exactly which one is the right plane, and then you can pull a little bit, trying to find the right plane, and then you are trying to work to find the plane you want to work. So don't be afraid of pulling a little bit, making small tractions in the area to find the right plane. I don't know if you agree. All of us, we don't like to make tractions. We like to avoid them, but sometimes it is necessary.
Yes, with the bipolar, of course, you do some traction, and we try to avoid the damaging of the sphincter by doing an early apical resection. So there's not too much pull on the sphincter area.
Absolutely right. So something that many times helps you is this, that when you are in the right plane, you are finding these lithiasis. The lithiasis are always between the capsula and the adenoma. So if you open and you begin seeing all the lithiasis, is that you are in the very, very right plane. Just follow the lithiasis, because the lithiasis will be marking you, will be telling you where the right plane is, and it is very easy if you find these lithiasis. Do you agree with me that this is?
Let me make a comment. I think there's many times you see amyloid bodies between adenoma and capsule, but when you see stones inside epithelialized cavities, these are probably prostatic glands. So maybe, you know, when you see the mucosa, you have to go deeper to take this mucosa out if you want to make a complete clearance of the tissue. Because often there is a small stricture in the meatus, and when the patients pee, there is a lot of pressure in the prostatic urethra. There is reflux of urine into the prostatic ducts, and then you have stones. And so many times you see these two different situations. This one, which I think it's dilated glands with stones inside, and then sometimes you see the periadenomatous amyloid bodies that tell you that you are in a good plane. In this case, I would go a little bit deeper to remove all the mucosal lining to clean it completely.
I do agree with you. In this case, it is not the right plane that you see when you're doing a transrectal ultrasound, that you see the lithiasis just marking the adenoma and the peripheral zone. These are glands that amyloid bodies that they are calcified. So I fully agree with you. But it was a good example just to explain the audience that sometimes it can help you to do that. We are doing the case, we are beginning, we are very happy, we are going to do our whole lab, and then when we are I always do a dilatation of the urethra. I take a lot of care of the urethra, and then I like to get into the bladder under vision, and then you find this situation, you have an stenosis. It was difficult, but at the end we passed a guide, so we have the guide and we have access to the bladder, but as you can see here, there is an stenosis. You don't know very well how to do it. It is in the bulbar area, very, very close to the sphincter. Now you are there. Which one is your option? Giorgio?
Well, when you face the stenosis, my option is if I'm passing through with the instruments, maybe with a little dilatation, I can easily start with my enucleation, and that's it. If it's something that it's long and should be treated not with the ureterotomy, maybe the problem of this obstruction is not dealing with the prostate, so I stop the procedure and we reconsider the patient for a better urethral surgery.
But if you are able to pass a guide, and because the stenosis can contribute, but many times also the prostate, it's the both things. So my question is not if the stenosis or the prostate is provoking the obstruction, that probably it will be both things, is If you find an stenosis, you go forward if you are able to pass your instrument, and then you do the enucleation.
The answer is yes.
Yes. Javi.
Well, I prefer, if it's a real stricture, it's not only mucosa, to put a catheter and reconsider in two weeks the surgery. And normally you don't find again this stricture. I prefer this. The problem is, okay, this is a private patient. He's coming from, I don't know, from another country, and you have to operate him. Then you have to consider the option of.
But let's forget the patient is coming, is paying everything that.
Yeah.
We are speaking about a real clinical world, the best for the patient. You prefer to go, or you prefer to take
for
care
example,
with the stenosis and
I
let's
prefer to take care.
take care.
Take care.
Goumas.
Goumas, come on.
So I would do an Otis urethrotomy. I don't want to stress the urethra because if I feel some resistance of the resectoscope, then there will be high chance that the patient will develop a urethral stenosis after the enucleation, and this will be a mess. It's a very bad scenario. So I try with Otis. If I cannot do it, I will try with a urethrotomy. But I want to feel the resectoscope free inside the urethra.
For not damaging.
The urethra. We don't have the MILEP set of Felipe. We are doing the 26 serie enucleation. I think it could be also a very good choice to have a reduced caliber resectoscope in your armamentarium.
Fernando.
No, sometimes when you go in, you think, wow, this guy's problem is a stricture, not the prostate. You see a long stricture, very tight, you stop the procedure. But very often, maybe 1 in 4 patients, 1 in 3 patients, you see mucosal rings that you can dilate carefully. So I'm with you. I think it's better to dilate or do a urethrotomy. The Otis works really well when you can reach, but if it's close to the sphincter, I think it's better to do a visual urethrotomy. And I have stopped the operation sometimes thinking that the patient's problem was the stricture, and then I discuss with the patient, how are you doing? Not good, so we need to do the prostate operation. So sometimes you have to do a judgment call. You have to decide what to do. Sometimes you don't know if you're doing the right thing or not, but you have to judge.
There is another situation, not very infrequent situation, that is that the patient has a meatus stenosis. And then when you are trying to put your instrument, you cannot get into the urethra. And for example, Francesco Montorsi, every single patient, he does a meatotomy and then he does the holmium enucleation. Which one is your opinion about this?
I use the Otis. The Otis is fantastic to do only the tip of the urethra. So you do a small cut, and usually the instrument goes in very easily.
But
And
not
I don't
routinely,
see
only the patients you don't have a good access, because Francesco
that's in everybody.
does a meatotomy in every single
I
patient.
think that's probably overkill. So if you enter easily, there's no need to do urethrotomy.
You know, sorry about this. We used when I was in the university clinic with the big professor, and he was doing this, and he told us to do this. And there was no democracy, okay? We had some patients that they said, now my gland is open and I didn't sign consent for this. So it's something invasive and you have to inform the patient. So we dilatate. If it's not possible, we do the Otis.
I have a meatometer from a store. It's the only brand that has. Is from 0 to 30, and I use always this for dilatation of the meatus, and I'm extremely happy with this.
Yeah, it's a conic dilatator you use in the
Is it-
meatus,
Exactly.
and it's the best
The
way.
best,
So,
yeah.
so you are not to cut; you just push it into, and it's fine.
If you put all is 30.
Yeah.
If 30 comes, you can start with 26, with 22, or what you want.
Me
You
too.
can actually enter yourself into the urethra.
About the urethral stricture again, I really wonder what the flowmetry would show before the operation. I'm sure that it has been done, and that way you can distinguish between a real clinical stricture or one that is just there to be passed, I guess.
Completely, fully agree. Let's move. We are now doing the enucleation. We found the plane. We are doing it, but meanwhile we are doing the surgery. We are doing this. We think we are in the right plane, but sometimes it is not very clear. The patient was with a catheter. Everything is like with a lot of inflammation with these cavities, or not. Or maybe you just make a capsular perforation like this, and you are seeing the fat above the capsula, and then what do you do when you do a capsular perforation during the enucleation, and how do you proceed on this? This capsular perforation is very small. I have bigger than this, okay, but I found this video. So how do you proceed with capsular perforations during the surgery? What do you do?
The most important thing is to always check where you are and to be aware that you have a capsular perforation. So if you see a big small hole, you have to be aware that you did a small hole, because sometimes you will follow this plane and the small hole will be big, and there is the big damage. So I will continue. I will follow my plane, I will continue. Oh. If it is not bleeding a lot, of course. That's another story. So I will continue, it's no problem.
No problem. Problem for...
I think the same perforation might not be a problem for you because you're a fast surgeon. So maybe you have a small perforation that leaks a little bit, there's some extravasation. It builds up during the operation, but you finish in 30 minutes. And then the patient has no clinical consequence. But if you're learning, maybe you're going to be there 2 hours, and then that patient will have a bloated abdomen. So I think when you do a perforation, you shouldn't panic. You shouldn't panic. You should consider if this perforation is going to cause trouble depending on the clinical situation. And one thing I tell everybody, and Nikif said it before, if you have a bad perforation, I mean, all the problems that we see with holmium, all the bad complications happen because you didn't stop the procedure. So if you're learning, if you're not very safe, you see a big perforation, probably it's much safer to stop, because nobody is going to tell you, why did you stop? You know, they will tell you, why didn't you stop? So I think when you come back some days later, the perforation is fibrous, it's sealed, there's no leakage, you can continue, you can take another route. There are many things you can do. You can lower the height of the irrigation, so there is less pressure, less extravasation. You can do transrectal ultrasound to check if there is big or not extravasation, so you can distinguish a not important perforation or a big important perforation. I think with confidence, when you get more experience, you don't care so much about small perforations. And I think it's very important what you said, recognize it and avoid it, correct your plane. But it depends on the surgeon, the speed, and the category. There's now a classification of perforations in grade 1, 2, 3, 4. So if it's a very, very deep perforation, if you see the water flowing outside, maybe you should consider stopping, because you will never regret to stop.
I agree with you. And in fact, for example, the number 4 is always a subtrigonal. What you say at the beginning, the most dangerous is these kind of perforations. It depends on the experience of the surgeon. And not, I think it's not the time of the enucleation, it's the time of the morcellation. Because the morcellation, you have a lot of water and a lot of pressure. And I think it's in that moment that you have to decide if, okay, we can go on with the surgery, or better put a catheter. And
well, if you palpate the abdomen on the sides of the bladder, because the bladder is usually palpable during labor, you can see it soft, and then you can judge, maybe I can continue, but you know, you have to be careful.
Sometimes in small perforations you also have bleeding, and if you lower the pressure of the water and you coagulate, it also tends to shrinken the tissue and thereby minimizing the perforation. So then you can decide whether to continue or not.
I would like to say that many times we make perforations in the capsula and then some liquid, you have extravasation. That liquid is extraperitoneal, so you are safe in the beginning, no problem at all, but there is liquid there, and if you put your hands, you feel that the abdomen is getting, as Gómez Sancha was saying, you feel the liquid. And sometimes, if you have too much liquid there, you can, it can begin irritation of the peritoneum, and then you feel like you have done a hole in the peritoneum and the liquid is coming into the peritoneum, but it is not. It is that it is only the irritation of the liquid that you have in the extraperitoneal space. So, if I have to give a counsel to you, I am following, last year in Torino, I heard Gómez Sancha, Fernando saying this, and I thought this guy is very right, because sometimes we always try to finish the procedure. But if you are in travel, this is BPH, nothing happens, you put a catheter, you send the patient 5 days home, you come back, and then you finish very comfortable the surgery, and nothing happens. Things happen when you are trying to end procedures that are getting worse and worse and worse, and you are putting liquid, and then you have to open the patient, a lot of fluid is coming out, peritoneal irritation and that. So my counsel is try to be patient, because with a catheter all the liquid will be out, but take care, because sometimes that liquid can provoke peritoneum irritation, and that is a very uncomfortable situation for the patient and for the post-op. Now we are doing the enucleation, and then we are doing the hemostasis, but we have a vessel that is bleeding like this one. You are trying to see it, you are trying to coagulate it, but you are with the laser, you cannot see very well. So my question is, I will be back here. What do you do?
Go ahead, Javier, what do you do?
A ver, Javier.
The coagulation, I think with the laser you can coagulate perfectly.
Sometimes it is impossible. What do you do? The first thing you say is, put pressure in the back, because
This
I
is
wanna see.
obviously.
And
No, but
somebody is pushing,
No,
then
but
more fluid is
sometimes-
coming, and you are with the laser
Yeah.
trying to close the vessel.
Sometimes you have the problem. Sometimes is the vessel is just pumping in front of you. So if you come from around or you can change. Obviously, you can change the settings too to be more hemostatics. And if you are not able to control this hemostasia, put the bipolar. It's not a problem. And the bipolar controls everything. Absolutely.
Bipolar.
Yes, we use a monopolar.
Monopolar.
Bipolar.
The story is that sometimes you try to do hemostasia with the laser, and you are putting the laser against the artery, and then you are making bigger and bigger and bigger the hole, and you are not able to close the artery. And then what was one artery bleeding now is a hole like this, and the artery is retracted, and you have no access to it, and you are in dangerous zone because you have no access to stop bleeding that artery. So the counsel here, and what I think all of us want to say, is that if you are in that situation and you cannot control very soon with the laser the vessel that is bleeding, take the monopolar, the bipolar, whatever you want, and go there and do the hemostasia, because if not, you are making bigger the hole and you are having a bigger problem. Do you agree with me?
Absolutely. It's
Yes,
a
but-
beautiful video of Mariano González doing this, and finally it was a big perforation, and what he see in front of him was the iliac vein.
The iliac vein.
So wow, this is a small problem you have been doing bigger.
You are going behind the artery trying to get it, and then you are just in the middle of nothing with a lot of fat, and then you can be in trouble.
One word of caution, though. You said that you ask someone to put pressure on the back, and if you listen to Traxair, he says this is a no-no. You shouldn't do that. because there is no way to know how much pressure this person is going to do in the bag. So for example, some guys I have seen how they hang their body weight on the bag, and suddenly you have, 1,000 centimeters of water pressure, and I had a bladder rupture like that. I saw the bladder rupture. And so I think it's better to resort to the bipolar or monopolar than having people pushing too hard.
I can be agree with that, but I think Olivier was speaking more in the renal when the laser is employed in the ureter than in the bladder and
But
in the capsula.
I lived a bladder rupture, so.
Yes, but that is strange. That is not usual. It is not so usual. So many times we finish the enucleation, and when we finish the enucleation, we have this situation. This is a not very strange situation, and then look here, that is the meatus, the right meatus, because it was with a very big median lobe, so you are seeing like that, the meatus, you see it, and we are now seeing the left one. And the left one is impossible to see because you don't know where it is. You are there and you cannot find the left one. You are seeing the right that is completely white and you don't know what to do. What we do?
So I remember your comment last time we were together and you did live surgery. I don't remember where.
Alexandria.
And you said
Milano.
Milano.
Milano. It was in Milano.
And in Como.
In Como. Absolutely.
And you said, don't worry.
Don't worry.
Don't worry. But this, we had stenosis of the meatus in a situation like this because I was not very careful. My younger colleagues now, they tell me, be very careful, okay, because we have to deal with the patient, with the colic. And first thing is to be very careful not to, okay, but if it happens, I resect because I think it's very thin. So I take the resectoscope and I cut the tissue there to find
a good mucosa.
Yes, that's what I do.
Fernando.
I would say that with these low penetration lasers, holmium and thulium, the chance of having a stricture is quite low. So most of the times I don't do anything. If there is some, of course, if you see the white coagulated ureter like that, it's a little bit more scary. And then, of course, you have the chance to resect the UO, put a double J stent, or take the chance and say, okay, I'm going to monitor the kidney. When this happens, I think patients have a renal colic when they get obstructed. But also, theoretically, it's possible to have a later obstruction. So in general, I wouldn't care in the majority of cases, but most of the times you burn, let's say, from 3 o'clock to 6 o'clock, and you see some nice mucosa, I wouldn't care. In a case like this, I would have doubts. And then putting a double J stent is not so bad. You have to explain to the patient what happened. He gets scared, he gets angry. So most of the times I don't do anything, but I would judge depending on the situation, and resecting the UO is probably a good idea.
Yeah, I agree. If you can see the orifice, I would look at the kidney, see what happens. But if you don't see the orifice, I would tend to resect as well.
And you, Javier?
Nothing. In my experience, nothing. Really, nothing. I have zero bad experience with these kind of problems. In fact, the only problem we have had is patients with stones in the ureter. And wow, now if you have to do a ureteroscopy is a problem. And in fact, in this kind of patients, sometimes it's very difficult to put the catheter now. So, okay, if he has no colic, wait 1 month and decide later what to do. Because now it's possible that you have more damage to the ureter than to do anything. And if something happens, for example, you have coagulate a lot with bipolar or monopolar, and then the patient starts with colics, okay, put a nephrostomy, and in 1 month, do the resection. That's all. In my experience, I have had one case, not mine, with a lot of coagulation, and that happens. Okay, both nephrostomies, and in 1 month we resect, and the patient without catheter goes on. So
Dimitri.
Yes, so frankly, Javier, it's a very hot question, and we usually discuss it during all VPH meetings. So we conducted a study on this topic once again. The study was published in International Urology and Nephrology Journal maybe 5 years ago. In some cases we put stent, in some cases we don't. So final message, no need. No need to put a stent. This is the final message. No need to resect the orifice, no need to put a stent. And the reason for that, before we conducted the study, we did several experiments in our lab, and we found the penetration level, thulium fiber and fulvium mechanism. So if we do a superficial, if we do enucleation, it's usually superficial resection, and there is no damage of deep tissue layers. So there is no scarring and no need of stenting in such cases. Of course, if you use afterwards, you use bipolar, coagulate this area, afterwards, blah, 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 of course you need it. But if you use laser, if you enucleate the tissue, you're moving, so no damage of deep tissue layers, no need for stenting. What we usually do, if this happens, so we monitor patients, we do ultrasound. So once again, and there can be a small hydronephrosis for a short time, but after 1 month, no hydronephrosis. No renal colic, no need for stenting in such cases.
but one consideration, sometimes the atrial nephrosis is because of the balloon of the catheter.
Absolutely.
I-
Absolutely. That's why we look for the symptoms.
Exactly.
I cannot be more agree with you. I have put 0 stents in my life in these patients. Laser penetration is 3 millimeters. So what happens is that you are damaging the mucosa and you are not damaging the ureter. So nothing happens. Sometimes the patient can be complaining of some pain in the kidney because he has some inflammation, because all that. And then you have to put the patient under corticoids and wait. And nothing happens, believe me. I have never put a pigtail in my life in these patients, and I think it is so superficial that it is not needed. But, we need probably more science. That is my experience, and that is my point of view of this situation. And we are doing the morcellation. We have beach balls, and we are trying to catch the beach balls with the resector because it is impossible with the morcellator. And then, oh my God, sorry. Well, it's the same. So when you are trying to beat the beach ball, you make a hole in the bladder, and then the hole many times is very big because you have so much distension of the bladder that with the damage of the bladder, the hole is not this size, it is this size. What are you doing in this situation? You have the hole, then you still have some beach balls or some tissue in the bladder. Which one is your option?
I think it's the same as the perforation of the capsule. You have to consider where is the hole, because if it's in the trigon, you have a problem, maybe. But if not, and it's not, you can go on. Probably stop with so much water. You can work with middle water. But if you have to coagulate, you have to stop and coagulate it, obviously, because if you don't have a good hemostasia, you cannot go on with the morcellation. But it depends on where is it the hole.
Yes. What I try to do when I resect beach balls, I try to do it in the fossa. So instead of resecting them in the bladder, I bring them inside the fossa and do the resection there, which is much safer.
Exactly. Me too.
I agree. But if there's a perforation, again, as you said,
And with beach balls, I prefer also to put it in the hole, and it's easier.
It is like, when we do TUR of the bladder, it's a big tumor, and I am also a little bit aggressive, and I see a big let's say, area, and I continue to
do the
resect.
morcellation.
If it doesn't bother you because of the bleeding, you go on. If you have bleeding, you have to stop. You have to coagulate and put a catheter maybe, and you come back another day.
That
Depends.
you have brought something I wanted to end with this, is that you have a big adenoma or some adenomas in the bladder. You have not a good vision because something is bleeding or the morcellator is not working well and you are not feeling comfortable. Which is the solution for you? Opening and then taking out the specimen and closing the patient, putting a catheter and coming back in few days to do the morcellation, try to finish the procedure. What do you do?
After 2 days, I finish. I put a catheter.
In 2 days?
In 2 days, it's beautiful and very safe.
Fernando?
See, I would agree. I think the scar, you carry the scar all your life. So you have the sensation that something failed and you have to carry the scar. But if you come in 24 hours, 48 hours, the tissue is usually smoother. We do these second looks under sedation because they're usually very fast. And the patient doesn't feel that it was such a bad complication and they forget about it after some time. But if they have a scar, they will remember.
Javi?
I don't have a lot of experience with the morcellation, but if it is a big adenoma, is it wise to wait a little longer so it can soften and the second look will be faster? That would be my idea.
Javi?
I agree with everybody. And in fact, for me, now the morcellators have changed completely, and now the time of morcellation is extremely good for me now. But I remember at the beginning, for example, when we were performing 300, 400 grams of prostate, it was more than 3 hours of surgery. I always stop at 2 hours, 2 hours 15, and I decide to put a catheter and repeat in 48 hours or maybe in 1 week. Because if the patient, for example, was carrying the catheter, it doesn't matter for him to carry the catheter for 1 week more. And later, in 1 week, this adenoma is extremely soft. So it's very, very easy. It's very, very fast. In 10 minutes, it's completely finished. And wow, it's wonderful.
In 1 minute, if you wait 5 days and you
exactly.
come back in 5 days, it is this size of the adenoma. It is dry, and the morcellator is so fast with it, and you have a wonderful view, and the capsula is retracted, and you feel very, very comfortable. Exactly. And my last question: when do you open a patient?
It never happened to me. No.
Only
During
one
enucleation.
day, that day that you open the patient. Why?
Okay, it happened with TURP, okay, some years ago, because of an extreme extravasation due to a very big perforation with hemodynamic instability, because we had fluid also in the retroperitoneal space, you know, in the supine position it goes all the fluid back to the kidneys. So everything was going very bad, hypotension, arrhythmias, and we had to open. So that's when you open.
Fernando.
Yes, very unlikely, very unlikely. Even if you have extravasation of water, you can put a drain. Most of the times the patient will settle, so no need to open as such. But in an extreme case, maybe there's no harm in opening if you need to. But today, I think it's very, very unlikely.
But can I say something? Sorry. It happened to me that patients went to the intensive care unit after enucleation due to sepsis, a couple of patients, and due to extreme reabsorption of water, even without perforation. And there were very big prostates and the patients fragile. And this is the concept of intravesical pressure. So in this kind of patients with heart disease history, you see the bladder that they don't have a very nice compliance. It's very thick bladder. you have to be aware that the intravesical pressure may exceed the interstitial fluid pressure or the venous pressure, and you may have, and it is described also in the literature, you may have encounter problems. That's why it is recommended in the literature the irrigation to be around 60 centimeters of water. This happened to me.
Yes.
And I'm very careful, and I do furosemide. Also today, the patient was, it was elderly. He had a natural fibrillation history, so maybe the reabsorption may cause some instability. So I was very careful about this.
Yeah, so we did a planned opening of the abdomen, but this was like a 350 or 400 cc prostate, which also had a 5 centimeter bladder stone. So we did the endoscopic enucleation, and of course the adenoma did not fit into the bladder, but then we did a small sexual alta and got everything out. So that went very well, but the patient got into a terrible sepsis and got into the intensive care after all.
Javi.
I think nowadays it's very difficult to consider to open a patient. I think it's different to consider before to plan, for example, a simple prostatectomy with robotics. I agree with you when you say that, because, for example, if you have a bladder hernia, or you have a lot of big stones, or it's an enormous adenoma, why not? Why not? But it's considered before the endoscopic option. So if the problem could be, of course, everybody is. It only happens to the people who operate. So obviously it's possible, but I think it has to be a very, very big mistake. For example, I remember that the last case I opened, I have thinking when it was and why it was. It was a morcellation of half bladder, absolutely half bladder. So we have to put the ureters into another part of the cap. It was a very difficult surgery. And what was the mistake? I was not in the OR, and it was operating the resident without control. That was only this. And
So,
okay, it's your mistake.
So in conclusion, I think that the message is that catheters are magic. So when you are in trouble, put a catheter, come the following day, open the patient only if you don't know what is going on and the patient is in instability, you are worried about it, and then you can open to put a drainage, to take some liquid out, to check everything, but if not, put a catheter. So I would like to ask a big applause for our experts for sharing with us